this lovely Tuesday afternoon. Excellent. Thanks, Sarah. Good morning, everyone, and thank you for allowing us to present you this no-cost CMS funded opportunity to help your hospital or hospital system accelerate quality, patient, and safety outcomes. My name is Lynn Chase, and I'm here today with my colleagues, Terry Lebowski and Sarah Butterfield. We're excited to walk you through what's available and how your organization can take advantage of it. As you heard, this webinar is being recorded. For those who are not able to join, we will be sharing both the recording as well as the slides following this session. Next slide, please, Sarah. Before we dive in, I want to give you a quick sense of how we'll use our time today. We have about 45 minutes together, and so we'll aim to present, but also allow sometimes for questions. We encourage you as we're going through, if you have questions, jot them down in chat to make sure we can address them. And anything we don't get to, we are all available after the webinar and offline to answer any questions you have. We're going to cover four things. What is the QIO program? Who's supporting this work? Where we can help hospitals and health systems, and what getting started looks like. As we go, please listen for places where this connects to your current priorities, needs, and/or strategies, whether that's readmissions, infection prevention, patient safety, data, healthcare technology, workforce, or emergency preparedness. Those are all areas that we can help support. Next slide, please, Sarah. And as I said, we really would like this to be interactive and good use of your time. We'd love to know who's on the call. If you're willing to put that in chat, your name, your organization, your role, and maybe one quality or patient safety challenge that your facility is currently focused on right now. We'll use those responses to tailor the discussion and identify where support may be most relevant for you. And again, as I said, if we don't get to everything, we are available after the session. So please let us know. Next slide, please, Sarah. Before we get into the program itself, I just want to briefly introduce who we are and the team that is supporting this work. iPro is a not-for-profit healthcare quality improvement organization who partners with healthcare providers like yourselves, communities, and government agencies to improve quality, safety, and outcomes. As the CMS Quality Innovation Network Quality Improvement Organization for both the Northeast and Mid-Atlantic regions, iPro leads this work in collaboration with my organization, Health-Centric Advisors, and our colleagues at Clarence. iPro has done this work for over 40 years, as has Health-Centric Advisors and Clarence. And iPro has been New York's quality improvement go-to since CMS actually first created the program. iPro is a physician-led multidisciplinary team that includes pharmacists, including Terry Lebowski, who you'll hear from today, nurses, social workers, analysts, dietitians, quality improvement professionals, and digital healthcare experts. Our team collectively has experience working across the full continuum of care, including hospitals, nursing homes, outpatient practices, home and community-based settings, as well as other healthcare organizations. Leading our team is Dr. Claire Bradley, iPro's Chief Medical Officer, and she serves as our program's executive sponsor. Dr. Patricia Gagliano is Northeast QIN-QIO Program Director. The breadth of experience that these three organizations bring together allow us to look at quality improvement from multiple perspectives and ensure that we're bringing the right expertise to the table based on an organization's need. Our work spans three broad areas: clinical quality, foundational quality infrastructure, and healthcare technology. The key point is that our participating organizations, when you work with us, you're not working with one person or one perspective. Through iPro Health-Centric Advisors and Clarent, you'll have access to a deep bench of experts who understand both clinical and operational realities of delivering healthcare, and we can provide practical, hands-on support tailored to your priorities. Next slide, please, Sarah. CMS oversees a portfolio of interconnected quality improvement programs that are designed to enhance quality and outcomes for Medicare beneficiaries across diverse populations. Services by QIOs are no cost to healthcare providers and beneficiaries. The QIO program has two core functions: healthcare quality improvement and case review. Both functions are carried out through four key initiatives. There is the Beneficiary and Family-Centered Care Quality Improvement Organization, or BFCC, and that's probably one most are familiar with. That supports Medicare beneficiaries and families who have care concerns and or need advocacy regarding discharge or service appeals. There are two organizations, Essentra and Commons Health, that cover the Region 1 area. And I'll update that to include the Mid-Atlantic coverage as well. I apologize. There is also the Native Indian Alaskan Native Healthcare Quality Improvement. And that's new this year. It's really supports Indian health services, tribal and urban Indian facilities with a lot of the same focus areas that we'll talk about today. There's the ESRD that supports patients through care navigation, quality improvement, emergency coordination, data analytics, and kidney care education. And then, as I said, the QIN-QIO is one of the largest federally funded quality improvement programs across the country. CMS directs the contractors, the QIN-QIOs, to collaborate with healthcare providers to improve outcomes for Medicare beneficiaries. In 2025, CMS launched the 13th scope of work to support healthcare quality improvement with nursing homes, hospitals, and physician offices. And this program runs through May of 2030. So when you enroll, you'll be able to get support until May of 2030. Next slide, please, Sarah. QIN-QIOs operate across the country. There are 7 distinct regions. iPro covers 2 of them, the Mid-Atlantic and Northeast, collectively supporting providers who care for 24% of Medicare beneficiaries nationally. What I think is important about that is that gives participating providers an extensive regional learning and network that covers 16 states and territories. iPro was awarded Region 2, the Mid-Atlantic region, in May of 2025, and Region 1, the Northeast region, in March of 2026. Region 1's award came nearly a year after the other 6 regions, which has really compressed the opportunity to enroll. And that's because CMS wants to ensure that all regions are up and running on quality improvement efforts. With that as a background, I just want to acknowledge that enrollment in both Region 1 and 2 end at the end of this month. And so part of this discussion is really to talk about the benefits, but also the fact of timeliness action to ensure that you're able to get support through this program. Next slide, please, Sarah. As we move into this new program, I would note that the QIO has evolved, but the center of this work is focused on quality and patient safety. For hospitals, that includes infection prevention and control, adverse drug events, falls and pressure ulcers, as well as avoidable readmission. It also includes prevention and chronic disease management, such as diabetes, hypertension, kidney disease, behavioral health screening, nutrition, and physical activity. The third area, new really for us, is transparency and interoperability to support care coordination. It's how information moves, how it's used, and how transitions can be supported. The fourth is supporting resilient, high-performing health systems, um, aligning the systems and workflow to make quality and safety sustainable. And as we go forward, we'll talk a little bit more about all of those areas, but if there's one in specific you have a question about, please jot it down in chat. Next slide, please. Thanks, Sarah. One important feature of this work is we can operate at multiple levels. We can support an individual hospital, nursing home, or outpatient practice. We can also support a system of organizations on a key focus area or priority. The best is when we're supporting a community of providers, the hospitals, surrounding nursing homes, outpatient practices, at community-based organizations, home health agencies, and all of those groups are focused on shared opportunities to enhance outcomes for the population they serve. Readmissions, I think, is a great example of that because the solution is rarely just inside a particular hospital, the four walls. It involves discharge planning. It involves follow-up. It involves patient engagement, medication management, post-acute communication, and patient and or family caregivers understanding. The structure of this QIO program is designed to support cross-continuum work as well as the individual organization. Next slide, please, Sarah. So when a provider enrolls, they receive 4 practical types of support. First, we can provide tailored assistance, working with your team to select evidence-based interventions and turn them into a realistic action plan that works in your healthcare organization. Second, we provide data, reports, dashboard, and also measurement support so that teams understand where to focus and also can monitor whether the changes they're making are making a difference. Third, the community connection. Talked about that sort of beyond the 4 walls. We can help providers develop pathways and protocols that support transitions and address health-related social needs. For example, a hospital implementing a health-related needs screening tool also needs to ensure that they have the community organizations who address each of those needs and create a follow-up or a loop to ensure that those needs are addressed and recorded. Finally, we're able to provide collaborative learning, and that's sharing best practices, tools, and lessons from peers across the 16-state territory region. I guess the message here I'd like to share is the support that we can provide is flexible. It's based on your needs. You identify who we work with, you identify what we work on, and you identify how you engage in this program, whether that's just a light touch or whether you want to have full engagement into the work. Next slide, please, Sarah. So I talked a little bit about the data we can provide, and I wanted to give a couple of examples to share of what we've done in the past and some of what we're doing right now. So the first is it's a high level. We leverage the data that is published, so it's publicly available on CMS Care Compare, but we put it in a really easy to use format so that providers are able to see a consolidated view on key quality and performance metrics. For hospitals, that profile includes the patient safety and complications measures, the healthcare associated infections, timely and effective care, as well as readmissions. We highlight comparison against state where it is available, and included trending data as well. Now, for hospitals, you may already have this data. You certainly have access to this data, but we do make it easier for you. For nursing homes, a lot of nursing homes don't necessarily even know this data exists. And so we're able to pull it down, make it easy for them. The first page of the report includes a snapshot of their performance. As you can see, it is color-coded to identify opportunities that they may want to focus on where they are outside of the state. It includes directionality of each of the measures. There is an overview on both the long and short stay measures, as well as a detailed section on staffing. The Q1 2026 data reports were just finalized and are currently being shared with enrolled providers. Why that's important for hospitals, and again, that's for nursing homes, why that's important for hospitals is nursing homes and these measures impact hospital readmissions, they impact hospital ED, also healthcare associated infections. And so these are data that we can provide that get providers to start to focus in on one area. Sarah, I'm going to have you go to the next slide, please. So in the past, we've also provided more timely and claims-based measures. So data that is not available in the public domain, it is your data, it is billing code data. And I just want to walk through what those look like and the types of things that we want to provide you going forward. So we had provided what we call a hospital care transition report. It included all-cause 30-day readmissions, live discharge, so numerator and denominator. It included both the facility, but also state, and we did regional comparisons for the QIO. We included a section on timing of readmissions, including highlighting percentage of patients who returned within 7 days and those that returned within 14. And we do that to help identify opportunities related to discharge planning, medication management, follow-up, and safe handoffs or handovers. This report also included a very detailed condition-specific readmissions for key diagnoses, primarily related to the hospital readmission reduction program, but also areas of focus. So AMI, COPD, diabetes with complications, heart failure, pneumonia, and septicemia. We have a section on the top index as well as the top readmission diagnoses, showing which conditions may be contributing the most to utilization. We had a demographic page that shows readmissions by age, race, and chronic condition to show higher risk populations and potential opportunities. We included also emergency department as well as observation utilization with the same level of detail. And finally, there was an entire section that was readmission by post-discharge destination, including home with no services, home health, and nursing home. And we were able to show, again, discharge to and readmission. And the intent of that is to show who is returning, why, how soon are they returning, through what setting are they returning, and to give hospitals actionable information to begin conversations and prioritize where they want to start, whether that's working with a post-acute nursing home group or working with home health to ensure that services are received. Next slide, please, Sarah. And we did the same on nursing homes. So 30-day readmissions, we included the ED visits, we have timing to return to the hospital. And with these reports, we broke it down from day 2, 1 to 2, 3 to 7, 8 to 14, 15 to 20, and then that 21 to 30-day interval, because the potential cause and what you do to address those based on the day is different. We also had a demographic stratification by gender, age, race, and disability status. We included the top diagnoses for the original or the index hospitalization, as well as for the readmission. We included ED visits, and we also included those that stayed for an observation stay. The intent of this data, again, is just to get both hospitals as well as nursing homes to begin to look at where there is opportunities. I will say that this data is usually, we had 2 files. We had a 2-month delay, and then we had a 5-month delay. And what we found was claims were not fully adjudicated, so they looked very different. So these reports typically had a 5-month delay, 5 to 6 month delay, but it gave you a better view of the care transitions, not only within your own facility, but we engaged the partners, whether that was nursing homes or other community partners, to look at their data. And this is the same type of data that we're looking forward to being able to provide during this particular scope of work. Next slide, please, Sarah. And I think when we talk about the work and what it can look like, it feels like there is a lot. And so I thought it may help to give an example of 2 types of interventions that we did with participants in the last scope of work. I've included, and I will put this in chat, a link to our quality award winners, so you can take a look at these as well as other examples. So the first, we worked within the 4 walls of the hospital. It really was focused on implementing a readmission reduction screening tool. 2, actually, 1 based on a clinical condition. We used a modified LACE, and the second, high health-related social needs. There was some connection with the community because we wanted to make sure that those resources were out, and we also wanted to make sure that there was an appointment scheduled, whether that was with a specialist or primary care, prior to the discharge. And that particular hospital achieved and maintained a 23.3% relative improvement in their all-cause readmission rate. Another hospital really felt like they had what they needed in terms of their internal process. And so what they wanted instead was to bring together cross-continuum partners in a post-acute network. We started by working with the hospital to identify the right partners. And our first session was called the Mind the Gap, where it identifies opportunities for improvement and then prioritizes those that the group will work on. We use data reports, but we landed on implementing standards across the continuum. So whether that's the clinical education and care paths, but also patient materials that were consistent whether the patient received them at the hospital, the nursing home, home health agency, or physician office. They were seeing the same language. And one example of that was sepsis. I am happy to report that that cross-continuum collaborative is actually still up and running, and they're excited to have the QIO support again. I am going to have Sarah go to the next slide, and I'm going to take a pause and hand it over to my colleague, Terry Lebowski. Terry?
Thanks, Lynn. So I was hoping what I wanted to do was kind of highlight some of our healthcare associated infection projects. And these were completed in the last CMS project, or the 12th statement of work. And if you look in the middle of this slide, you'll see two affinity groups. So we ran two of these, one on the topic of penicillin allergy and the second on Klebsiella prevention. And we brought the goal of these was to bring together hospitals with interests in either one of these topics. And as a result of the affinity group, we had the development of resources, several opportunities for sharing of best practices, and also gap assessment. So people could see what others were doing with these topics and how they got started, how they got funding, etc. On the left side, antibiotic stewardship assessment. This was a project that we completed with approximately 30 hospitals in our program. And the goal was to assess your own antibiotic stewardship program. And I'll show you an outcomes report from that project in the next slide. Bottom left is our hand hygiene project. And this was completed in 78 nursing homes in the last scope of work. And what it did was it provided automated, detailed bedside audits of hand hygiene competency, and observations in the nursing home setting. And our goal for this next statement of work, this new work with CMS, is to expand this to hospital practice. So to continue with the nursing home, but add hospital practice. And the dashboard will provide hospitals the opportunity to filter real-time, detailed observation data, along with the ability to benchmark your data to other hospitals in the state and in the region, like Lynn showed you, the big region. So we're hoping to get participation across that region, give a very nice and complete benchmarking data. Next slide, please. So this is a copy of our antibiotic stewardship assessment report that we provided to the 30 hospitals that participated in the project. And again, each of the hospitals completed the assessment of their own antibiotic stewardship program. And they looked at how many, according to the core elements, how many basic, intermediate, and advanced antibiotic stewardship activities were current and being implemented. And then we provided them each hospital this report, which showed your facility data as well as this benchmarking data. So all participating hospitals, and then all participating hospitals in your state. So it gave like 2 layers of benchmarking for all the people, all the hospitals that participated in the project. Next slide. Next slide, please. The next thing we created was our iPro antibiotic prescribing map, and it's based on Medicare Part D data. And the far left side of this slide shows the filters for this baseline, for this map, this prescribing map. And the filters can be applied to the map. They include the year, so you see the year entered there, the state or multiple states like that are shown in this example. It can be filtered by county, drug class, and antibiotic name. So what you're seeing here is the drug class of fluoroquinolones on the heat map in the middle. So the states presented here are New York, New Jersey, and Pennsylvania. And the red and orange colored counties are those with the highest prescribing rates. And it's measured as rate per 1,000 member years. The table at the right gives you more detailed information down to the actual county. You'll see on the left here in the table. Then it also shows the associated prescribing rates, the average days supply, the quantity dispensed, and the total claims. So this map, what I'm envisioning for this next work that we're embarking on, will be covering that huge Northeast and Mid-Atlantic region. And this will provide assistance to your hospital AS assessment of outpatient community prescribing patterns. And like Lynn mentioned already, we do want to get into this whole community effort, and that certainly outpatient prescribing influences inpatient, when patients come in with resistant organisms, et cetera. So it is a key piece of that puzzle. So this data may be used by you to educate your providers on county-level prescribing patterns. So that's our very nice antibiotic prescribing map. Next slide, please. And this is the sister map. So this one is the opioid dashboard. And this is also based on Medicare Part D data for fee-for-service beneficiaries. And the goal is to support the efforts of organizations, community partners in improving opioid prescribing. And the dashboard shows the rate of opioid prescribing as a heat map, again, similar to the antibiotic one. You'll see it at the top there of Massachusetts. And then the legend for the heat map is right next to that. And then to the far right, you can filter the dashboard to show a particular time period on the map. And you can select either all opioids like you're seeing here, or you can filter to the specific morphine milliequivalent grouping. At the bottom left, there's some information on the opioid prescribing by county, and I think this is very interesting. It gives you a real quick look at the different prescribing rates by county. And then to the bottom right, if you wanted more detail, you can see the county level change in prescribing patterns over time. And the interval to the far right is the most current data. And so it shows you just a nice picture of prescribing and changes over time. So as Lynn mentioned, like when we're talking about like prescribing, one of the issues that we want to work on with this next CMS work is on opioid and benzodiazepine co-prescribing. And it says hospital in the measure, but really we know there's a big influence with the community prescribing. And I didn't show it on this screen, but another part of this dashboard includes the combination of opioid and benzodiazepine prescribing. So it's our goal to update this and include more of the states, and it'll be all of those that we showed earlier on that. Back to you, Lynn.
Great, thanks, Terry. Thanks, Sarah. So I thought it would make sense again to highlight some of our current offerings as we're still in the final weeks of enrolling providers. We are offering several opportunities for those who've already enrolled to get started. And so some of those examples for infection prevention, Terry and our colleague Mary Ellen Casey run a bi-weekly peer learning session. Again, great opportunity because it's 16 states and territories coming together. And this is for, it's called Hospital Topics and Infection Prevention, or HTIPS for short. These groups come together. The first part of the session is really didactic, focused on the current evidence base. But the magic comes when providers share what they're doing around that. We've had some hospitals recently from Rhode Island who came in and shared some of the work that they've been doing. This is new for us with the hospital IPs, but it really has been something that the participants have found a value. All of these that I'm talking about are on our website and are available for enrolled providers. So if you're interested or you don't find what you're looking for, let us know. We're happy to send that to you. We also offer for nursing home IPs infection prevention for infection preventionists by infection preventionists. And that's led by Melanie Rhonda, a former DON and infection preventionist, along with Mary Ellen Casey, our hospital infection preventionist. So they bring both the knowledge, but also the experience working in these care settings. That has been a really great session. We've had that up and running actually for a few years now. Nursing homes find value in that. There is a Facebook page that is pretty active for sharing across the states. And again, why hospitals care about that is infection prevention. So one of the drivers for unplanned ED transfers and subsequent readmissions. So that session is great. They actually just hosted a 2-day workshop for brand new infection preventionists in the nursing home that had reached maximum capacity. They're offering one more. I just got the date today. It's October 6th, and it will be a full day session based on demand. So we also have a patient safety, a falls affinity group. Falls are a focus in hospitals, in nursing homes, and outpatient practices. And there are folks that wanted to get up and running and started. And so we're kicking that off. We have foundational quality support. So I mentioned the data reports, those standard analytic report or SAR report for nursing homes. Q1 2026 data is available. This is publicly available data, but it's not easy to get it in this format. And so this format makes it easy to get and also easy to understand. Helps to identify opportunities. Those are available for all enrolled providers, all enrolled nursing homes. We have it's a 6-week session, Quality Improvement 101, where we offer training and then a coaching call to apply. So as participants join, they identify a small QI project and they implement that over the 6 weeks. So not only are they getting the knowledge, the tools, but they're actually getting the skills. And that session kicks off actually later today. So they will be doing training calls on Tuesdays at 2. Thursdays at 2, they do the coaching office hours. It's a certificate program. It is really great for those folks who are new to QI or quality adjacent and who will be involved. Really good refresher too for those folks who haven't gone through it in a while. For nursing homes, we have what's called the Workforce Water Cooler. Workforce, the turnover in nursing homes is astounding and has grown. This workforce water cooler is a great 15-minute check-in to share best practices. What's working? What are folks doing to help with both recruitment and retention, recognition programs? Anything that supports staff stability, and again, why do hospitals care? Because if nursing homes are not well staffed, one, care transitions, that discussion is an introduction every time there's turnover, and 2, well-staffed facilities are less likely to send out to the ED. They're more able to treat in place. Our emergency preparedness team is excellent. We have one of the leads comes to us from the military and the other comes directly from FEMA. They have created an emergency help hub app that's available both for providers as well as consumers. A great resource. From the support perspective, the team offers an AI-supported plan review, reviewing emergency preparedness plans and also providing suggestions on where there may be some opportunity to enhance them. They offer a number of really well-designed tabletop exercises, as well as customized support for folks who are new and want support on emergency preparedness. One of the areas that is a focus, and we've heard a lot from providers, is workforce violence and supporting your workforce. And so that is an area that also sort of falls under that emergency preparedness. And the final area that we support is advancing healthcare quality technology. And we offer both an assessment on current level of technology use, and then based on where a particular organization falls, tailored support so that they can take the next steps, whether that's implementing a new module, a health-related screening tool for their EHR, or whether that's adding remote patient monitoring, or perhaps an AI scribe. It's really, again, customized and supported based on where that particular organization is from. And I know the enrolled providers have already started to clamor on these particular offerings. This is before the quality improvement process starts. Again, we are wrapping up enrollment in the program at the end of the month, and starting September, really moving into the quality improvement phase, which is tailored to each individual provider. Next slide, please, Sarah. I just want to acknowledge, I know providers are getting a lot of outreach from vendors and from folks, especially with when there's money available. And so I really want to reiterate that the QIO program is CMS funded, it's CMS endorsed. It is a resource that is available to you at no cost to your hospital. You can unenroll at any time if you do not find value. But the time to enroll is running out. CMS has identified the enrollment window through the end of this month, and after that, we cannot enroll somebody new. But if you enroll and then say, hey, I don't, this isn't for me, you can unenroll anytime. And we will share these slides. We have included the links to where CMS on their web pages have highlighted participation. This is a voluntary program, but it's really no risk for providers. If you don't like it, you don't join. If you do like it, you join, and then you identify what areas you want to focus on. Whether that's a community-wide effort to enhance knowledge around sepsis or COPD or CHF, whether that's infection prevention within the four walls of the hospital. You get to determine that, and we'll work with you on crafting the tools and resources to support that. Next slide, please, Sarah. So if you're interested in joining, if you're even just slightly interested in joining, I encourage you to enroll now, and you can always unenroll. Make it very easy, or as easy as possible. You can complete the agreement. It is just an agreement. It's not legally binding. You can opt out at any time. You can scan the QR code, and it brings you right to the page where you just provide your information, or reach out to one of us after, and we can follow up. You determine how you want to engage. The meeting cadence, how often, duration, focus, frequency, who you want to involve. Terry talked a lot about our work around opioids and antibiotics. You may want to only involve your pharmacist, and we have had hospitals that do that, or just the quality group, or you get just nursing. You get to determine that. And then how you want us to communicate. Is it, we've had systems that have enrolled and they have one point person, and we do everything through that one point person. We have other systems that have enrolled that want each hospital to have their own unique approach and contact. You get to determine that, which is a really nice part of this work. We do assess your quality improvements as well as your technology. So there are two assessments, and you can determine whether you want to do that by yourself. It's a quick red cap assessment for both of them. Probably will take you about 45 minutes to do both, or we can set up a quick call and just have a discussion, and we can fill that out for you. During that first session, once we complete your assessment, then we develop a plan. What is the action plan? What are the first couple of priority areas that you'd like to address? We refine as we go, and every year we reevaluate. That this program really is intended to support and service your needs. I also just want to acknowledge, circling back to data. For hospitals and nursing homes, we have your data. So the claims data we're able to use, we're not asking for additional data other than we are asking hospitals to confirm rights to their NHSN. It allows us to pull the data and assess progress, but it also gives you an extra set of eyes to make sure that things are being submitted completely and accurately, and most importantly, on time. I just wanted to acknowledge that because some programs do require a lot of data submission. This is intended not to do that. Next slide, please, Sarah. I just want to pause and see if there are any questions. I do see a comment from Martha about MedHealth Maine, and that's fantastic, Martha. Terry, I'd invite you to jump in, but I know that's one of those things we're always looking for programs within the communities that help address a gap, and certainly health-related social needs, such as the cost of prescriptions, meds, and supporting that can be a significant barrier. And so it's lovely that there is this program. We find that making providers aware of these types of programs and also figuring out how it works within their workflow for referral and follow-up is something that makes it successful. So we're looking forward to talking to you more about that and figuring out how we can incorporate it. Next slide, please, Sarah. And I know I went over, so I just want to acknowledge if you need more information, I've included Sarah's contact information, Terry's contact information, and my contact information. We're looking forward to being able to support your quality needs and looking forward to working with you over the next couple of years. Thanks so much for your time and attention. As I said at the start, we will share these slides, we will share the recording, and if you have questions or needs, please don't hesitate to reach out to us. We're looking forward to working with you. Have a great day, everyone.